Magnus, Ohman, and Ralph Brindis returned with Dr. John Spertus, Director of Cardiovascular Research at the Mid-America Hospital at St. Luke's in Kansas City, Missouri, to discuss testing an evidence-based, individualized, informed consent form to improve patients' experience with PCI.
So welcome both of you to ACCEL.
Thank you very much for the opportunity.
So John, tell us a little bit how you came about with this project even in the first place. What was the driving force here for you?
Before I actually get too into it, I just, in the interest of transparency, want to disclose that we've recently started a company to help support and disseminate this tool called Health Outcome Sciences, and they have a relationship with the ACC to translate some of the risk models that the NCDR develops for quality purposes to the bedside for individual patient-level decision-making. And I got really interested in this because we've all have a strong commitment to practicing evidence-based medicine, and that's really driven by the guidelines and the summation of the clinical trial experience that trialists like yourself generate. And what was really apparent to me is that those trial summaries are the average benefit for an entire population of patients. But within any trial, some patients do very well and some do very poorly. And the ability to risk stratify those patients and figure out really who benefits most from our therapies and to be very aggressive in treating those and who may benefit less and whom we probably should not be as aggressive treating seems to me to be one of the great professional challenges that we face. And so the hope and idea was to build the infrastructure to execute complex regression models, which are very sophisticated ways of risk stratifying patients, and allow those to be run on a patient-by-patient basis in the routine flow of clinical care. There have been risk calculators before. I mean, they've been around for decades, but they seldom get used because they're not integrated into the routine flow of care. And so that's what we really sought to do with these personalized consent forms is every patient who undergoes angioplasty has to get informed consent signed. And if we could marry that informed consent process with an individualized estimate of patients' risks for decisions that are really relevant during angioplasty, we thought that would be a real innovation. And so that's what we tested in our study.
So what sort of variable or what were the information that you provided to the patient as part of this consent? And I presume from Ralph's point of view, you derived all of these in the NCDR database for angioplasty. So which were the key variables that went into this?
We did several things in creating the consent form. First, we reconceptualized the form itself. So we brought the educational level, the reading level of the consent forms in our study was as high as the 16th grade level, meaning you had to be a college graduate to read and understand it. And we brought it down to the 8th or 9th grade level. And then we embedded in it educational documents to inform patients what's an angiogram, what's angioplasty, what's a stent. And then we included risk models from the cath PCI registry, the risk of dying, because that's a sort of a legally mandated obligation that you tell patients there's a risk. And here we could give them what that risk was from the NCDR mortality model that they've used. Bleeding risk, because not only is that an important complication from patients' perspective, but there are things as interventionalists we can do to mitigate that risk. A radial approach, bivalve, etc., which are exceedingly valuable in higher risk patients and may be very cost ineffective in low risk patients. And then the risk for having to come back in a year for a repeat procedure for target vessel revascularization if you got a bare metal or drug-eluting stent. And all three of these models or sets of models are, published models from the NCDR that use clinical variables that are known prior to the angiogram happening. And we've had to do some sort of tricks in the restenosis model because, as you know, large and important determinants of restenosis are lesion length and vessel diameter. And you don't know that because the consent is done before we get to the cath lab, since so many of our angioplasties are ad hoc.
I guess two variables, and I'd be interested in Ralph's comment, two variables that we typically talk about when we do angioplasty is the risk of myocardial infarction and the risk of stroke, because stroke is an important variable for patients. Should these be included? They are in the NCDR database, are they not?
The challenges we have related to periprocedural myocardial infarction is accuracy in terms of assessing that within the NCDR. So we've shied away a little bit from that. What I find particularly amazing about this particular informed consent tool is its value not only to the patient and the family, but also to the clinician. I think John's work here has really informed the clinical community because oftentimes they under risk, if you will, what is about to be before the patient.
I think that's a very good point. Now, let's get back to this randomized trials. How do you perform randomized trial now using a process in the hospital, so to speak?
It actually was not a randomized trial, which is what I would have loved to have done had we had a bigger budget. The ideal way to do this would be to track a group of patients and randomize hospitals, because you are fundamentally changing the structure and process of obtaining informed consent, and clinicians have to adopt a new style of eliciting consent when there are these kinds of educational documents and risks available to them. So what we were left having to do was a pre-post implementation study where we tracked patients' experience with each hospital's original consent form, then changed them over to the PRISM and looked at the difference. And we felt that was okay, because the thing you're most worried about when you do these pre-post studies is a secular trend, a change in the general practice pattern. But informed consent hasn't changed for decades.
And we're in a pretty stable environment for angioplasty. It hasn't changed a whole lot in the last 5 years.
That's exactly right. And so what we did is we thought about, if you were going to test whether a consent like this was beneficial, well, what would you think would be relevant outcomes? And the relevant outcomes for this specific intervention would be, well, do the patients engage in the consent process? I mean, do they even read the consent form or understand it? 2, do they understand that there are risks of the procedure and what those risks are? And 3, do they participate in shared decision-making around getting a drug-eluting or bare metal stent? And so we asked patients about that, about 590 patients using the traditional consent forms across these 9 centers, and another 527 patients when we had already introduced the PRISM consent form. And what we found were really substantial improvements in all of these domains. Patients read the consent form much more often. They understood it. They thought the information was clear. They were less nervous. They understood the risks of bleeding and death and the purpose of the procedure more. And they talked with their doctor much more about whether to get a drug-eluting or bare metal stent, and felt they were more involved in that decision. And across the board, on average, there was about a 2 to 3-fold odds ratio increase in each of these outcomes. There were 2 points I'd like to bring out. One that was really surprising to me was how much variability there was across hospitals. So some hospitals had 10-fold increases in some of these outcomes, and others actually got worse. And so it was really a lot of variability. I mean, overall, for each of the outcomes, about 6 or 7 of the hospitals got better, 1 or 2 got worse. It wasn't always the same hospital. So it was a very interesting issue, and we're doing a lot of qualitative research to understand how implementation changed so we can better do it. I think it is attainable for all to do better. And some of our sites, we weren't as sophisticated in implementing it as we would be if we were starting the study today. And the second thing that really was a little humbling was when I described some of these opportunities, like discussing drug-eluting stents, less than a third of patients talked about a stent type with their doctor before angioplasty with the original consent form. And it went to about 62-65% with PRISM. That means even after you introduce easy-to-read consent form with explicit risks to the benefits of a drug-eluting versus bare metal stents, a third of patients still don't talk to their doctor about that. And I think that's astonishing to me. So the glass is half full, and that we made an improvement. It's half empty, and that there's a lot of room to go.
So, Ralph, what are your thoughts here? I mean, this is obviously a huge step forward in the practice of informed consent. But what are your intuitive reaction to how should we implement this nationwide?
First of all, we were thrilled at San Francisco Kaiser Permanente to be one of the sites, and I can tell you from our clinician point of view, nurse point of view, and also our patient point of view, we really do think this is a step forward. When you think about the next step is how do we improve patient medical adherence? And clearly one of the big barriers related to adherence is the issue of the concept of low health literacy. And through Dr. Spertus' study, through his tool, we're going to improve health literacy, which I think is going to conquer some of the barriers in medical adherence after we put in these stents, for example.
There were some hospitals that actually did worse, or there was some worsening. Can you share with us what you felt that could have been due to? Because obviously those hospitals, for what I can judge, may have been pretty good at what they were doing.
All of the hospitals were terrific technically in doing angioplasty, and I think that we allowed hospitals to customize their implementation of this consent into what fit within their workflow. And some of the hospitals did not completely replace the consent form with the new PRISM consent form. Others didn't. And I think if you have some patients getting treated with an old consent form, some with the new PRISM consent form, it's hard for the doctor to establish a rhythm in using it. Secondly, we didn't do as good a job as we should have done in working with doctors and teaching them how to use this consent form. I mean, it is different. And we were very nervous. We had tremendous respect for the cardiologists and the interventionists that we were working with. It seemed inappropriate to us to sort of go through how to do a informed consent when they've been doing it for 20, 30 years, some of them. So it seemed wrong to us. We should have had more confidence to do that because it is different and it's a different strategy. And so I think some of the barriers that we really saw, why some hospitals got worse, had to do with variability in the commitment and implementation they had, and doctors getting comfortable. And I think that over time, this was a very short study. It was actually funded in part by ERA funding, so it was a 20-month study for a 5-year R01. Had we had more time, I think we'll continue to see improvements in all of these parameters as doctors start getting comfortable with it and working it into their flow.
I want to thank both of you. This has been a fascinating discussion. I think one of my take-home messages in all of this is that not only did you think we had better communication among the patients and physicians, but there was also a wake-up call for the physician at the comfort level of what they saw and the risks of outcomes would be. And as Ralph always pointed out, the physicians, sometimes when confronted with information that is based on NCDR or observation registry, brings us to a new level.
Congratulations, John.
Thank you so much for the opportunity to spend time with you.
Thank you.